Hello, and welcome to the first VICE Rounds video, Veterinary Isolated Clinical Education, a volunteer crowdsourced continuing education platform for students unable to attend clinical clerkships in person due to the coronavirus safety recommendations. We hope these rounds recordings will help you develop as a clinician in spite of these circumstances. If you are a veterinary educator interested in participating, please see the informational slide at the end of this presentation. My name is Dr. Alex Fox-Alvarez. I am a boarded veterinary surgeon in Florida, and I'll be walking you through a typical clinical scenario for Brachycephalic Airway syndrome. Okay, so here we have Sebastian Osco. Sebastian is a 15-month-old neutered male bulldog mix, and I say bulldog mix because photos and videos of Sebastian are going to change throughout these rounds, just so that I can give you some good clinical images from different cases that I've had. His presenting complaint is that he snores when he's sleeping and sometimes when he's awake. Can't mock more than a block, and once turned blue during a 4th of July party because of all the excitement and the heat. Here he is on presentation.
He regurgitated twice in the
So, what are some of your major concerns regarding this patient just seeing this here? And why do you think this is happening now? Why don't you take a few minutes to either write down some answers to this or discuss it amongst a group if you're doing this in a live setting? So he seems to have some difficulty breathing, a little bit of stutter for sure. And what you can see is he's kind of hard swallowing and focusing there. It almost looks like, and it most likely is, that he's regurgitating or having some reflux and hard swallowing that back down in this moment. And this can happen because of how difficult it is for them to breathe and how much negative pressure they have to generate in their chest, which we will touch base on a little later, but also can happen just because they're getting excited and handled and having to try a little bit harder to breathe, and this is causing a little bit of that reflux and regurgitation. So after a little while, after your examination, the dog gets a little worse. It starts to sound like this. So what treatments immediately can we do to support our patient? Take a few minutes here to either write some answers down or discuss amongst your group if you're doing this in a group setting. So first and foremost, oxygen for Sebastian is going to be a big one there. If you can get him in an oxygen cage, it'll be better than flow by oxygen. You'll be able to achieve a higher concentration. Maybe related to some of his excitement. His excitement may be exacerbating this. And so a sedative such as acepromazine or dexmedetomidine may be a good idea. And then you want to make sure that the patient is cool. Remember that they keep cool by breathing, and with this abnormal respiratory anatomy, they're unable to exchange heat efficiently. So they can overheat just by getting really excited and worked up. And then you'll just want to give him some time. Just give him a little bit of time to collect himself and chill while maybe you go talk to the owner and get a bit of a better history. And that's what it's time for right now, a talk with the owner. Here's the owner. This is Mustache Mike. He's actually my neighbor, and he volunteered to be a model for this. So thanks, Mustache Mike. And Mustache Mike loves his dog very much. So what kind of questions do you want to ask the client about the history? Go ahead and take a few minutes to write some things down or discuss this with your group if you're doing this in a group setting. So some things we came up with were, how often does he have episodes like this? How often does he have difficulty breathing? Has it progressed over time and getting worse, or is it unchanged? Does he have exercise intolerance or heat intolerance? Does he tend to get overexcited and that's when this happens? Does he ever vomit or regurgitate, and if so, how often? Does he cough? Has he ever had pneumonia that you know of? How is his breathing like this impacting his quality of life, which is a huge and very important question to ask. And how has he done under anesthesia in the past, if this is applicable? So how would you explain to the client what's causing this in his pet? Again, take a few minutes to write some answers down or discuss this in a group if you're doing this in a group setting. So there are many ways to approach client education, and one of the great things about clinical rounds is you kind of get to see everybody's individual approaches to things. And so I'm going to run you through my individual approach of client communication, specifically with Brachycephalic Airway syndrome. So the way that I kind of approach all client discussions is that the better they understand what's going on, the more likely they are to follow your recommendations and understand the risks. And so in this case, I will intend to cover why this is happening. So why is this happening to my dog? I want to discuss the breed morphology in an understandable way with them. What does it mean? I want to explain how these abnormalities affect the normal body functions. How can we fix it? Discuss treatment options and overall goals of surgery. Discussing what the risks of surgery are and why brachycephalic breeds may be a higher risk for anesthesia. And then also covering what else we can do, our medical management and other things to consider as well. So why does this happen? Well, it's due to a constellation of abnormalities called Brachycephalic Airway syndrome. And this is due to an extreme breed morphology, bred for an abnormal skull shape. And so, if you look at this image here, it's pretty crazy. This is all the same species of animal. And so, a St. Bernard is the same species as a Chihuahua, and yet just look at the morphology differences between their skulls. And so, we've taken a creature maybe more similar to a wolf here, and bred it into dogs similar, the dolichocephalic breeds with long-nosed dogs that are similar, but we've also bred them for very extreme skull morphologies, such as the bull terrier here, but then these brachycephalic dogs, the Chihuahua, French bulldog, pug, and you can see that all of this, all of this bone here and everything within it, with everything within the nasal area here, it's compressed and squished into this tiny little area that looks like a little squid skull. And so all of that abnormality, or all of that anatomy, is still there. It's just now has so much less real estate for it to exist in, and so this is going to cause some secondary problems. And you can see that this is getting worse over time. This is from the Natural History Museum in Bern, and it's a change in the skull shape of the British Bulldog over the last 50 years, and you can just see that the nose and some of the changes in the sagittal crest and in the jaw are just, they have these dramatic changes over time. And so we're breeding for more and more extreme morphology, and it's causing these abnormalities in this dog. And so really the best way that we can combat this is by trying to breed some of these negative characteristics out of these dogs. Okay, so I'm going to kind of work through Brachycephalic Airway syndrome from the nose back, starting with stenotic nares. So there's 4 big components that make up Brachycephalic Airway syndrome. Stenotic nares is the first. And you can see this is a difference here between a brachycephalic breed. So you can essentially see these nasal apertures are just tiny little slits. I mean, can you imagine? Just try and pinch your nose now, and it's very difficult to breathe, through a little bit of a pinch on your nose. Versus a normal dog here, you can see they won't have as much resistance breathing through those large holes. And so we're starting just from the nose alone. The entryway up there being narrow and having kind of very narrow opening, making it more difficult to breathe. Next is the elongated soft palate. Here's a beautiful video of that in action here. And essentially the soft palate, which is up here, is going to it's too long. So the epiglottis here, it's going to be sucked into the trachea, over the epiglottis. And you'll see that here. I just wanted to explain it before, and you'll see why it's very obvious. You probably won't be able to hear me. Pretty impressive. I mean, he has to slurp through, all that soft palate and pull real hard just to get to that. And so that's abnormal and obviously something that's going to contribute to a problem here. Another thing we're learning, though, is that the palate is also, this is a cross-sectional CT, is also thick. And so not only is it too long, but it's also pretty thick, and it's going to kind of, obliterate some of this nasopharyngeal region here for the airways. Something to consider, and we'll touch base on that a little later as well. Next is the everted laryngeal saccules, and this is actually early laryngeal collapse, but essentially these are everted laryngeal saccules here, okay? And those normally sit in the opposite direction. However, with while they're generating all this negative pressure and they pull really hard, it flips it inside out. So it's sort of like a sock up and in the airway. So it's getting sucked and pulled up into the airway, and it's going to remove, a big portion of the ventral border of the airway here. And so it's contributing to there being, a lack of airway here and an increase in airway resistance. And you can see in this patient, there's greater degree of laryngeal collapse here with the cuneiform cartilages touching, and it seems like the dorsal rumen may also have some laxity and medial deviation as well. And so here's a video trying to show you guys some averted laryngeal saccules. It is a challenging thing to capture, but you can kind of see here that's that area where those averted laryngeal saccules were, and we'll touch base on this shortly as well. And the last one is the hypoplastic trachea. So the hypoplastic trachea essentially just means that it's smaller. There's less trachea there, okay? And so the way that we look at this is a tracheal size ratio, and it's a tracheal diameter over the thoracic inlet diameter. So we're looking here at the tracheal diameter on a lateral versus the thoracic inlet diameter. So that fraction. So tracheal diameter, thoracic inlet diameter. And so brachycephalic dogs are much lower. They're, closer around 16% versus a normal dog that may be, 20, 23%. And English bulldogs are even lower. They can be down, in 13% there is what's been out in the literature. And so this is a common thing to see for sure. It's just unfortunately the one thing that we can't address surgically. And it's definitely contributing to, the overall narrowing of the airway. And so what does this mean for Sebastian? So overall, the airway is too narrow, and it's making normal breathing much more difficult. It's requiring much more effort. We can improve his clinical signs by increasing the diameter of the airway. And we know this from, hold on. Okay, and... Poiseuille's law, which states that airway resistance is inversely proportional to the radius to the fourth power. And so the radius being to the fourth power, it puts a massive effect on a small change in the radius. So just a tiny little change in the diameter and the radius would make a massive influence on resistance. So you can think of this, and I talk to clients about this, you can imagine drinking through a cocktail straw versus a regular straw or a boba tea straw, and how much more difficult it would be, despite there not being a huge difference, measurement-wise in that size. It's just compounded so much more. And so as this example here, a pediatric airway, or a tiny little airway that's about 4 millimeters, just 1 millimeter of inflammation, or narrowing, it's going to decrease the total cross-sectional area by 75%, which would increase the resistance by 16 times, which is insane. And the same would be true in the reverse. So if we were able to remove a millimeter, 360 around here, then we would have an increase in 75% and a decrease in airway resistance by 16-fold, just by a little small percent. So what we do is we work every location that we can to try and open up this airway and chip away and make that a larger, radius overall in the airway. And so what about his regurgitation? It's a good point, Mustache Mike. That we are worried about that. We do have that going on as well. And so why is that going on? It's likely secondary to this brachycephalic airway syndrome. When you breathe, your body here, as you can see in this image, your diaphragm pulls down and it creates a negative pressure, creates a vacuum in the chest, which expands the lungs. Okay. And so when you breathe out, it comes up and it decreases that negative pressure, and then the lungs will deflate passively. And so these dogs, because of their abnormal airway, I know that this is a human, but bear with me, they have to pull much harder. So they're pulling really hard, much harder than we would need to, and then a normal airway would need to fill these lungs to overcome this increased airway resistance. And so another structure that runs through the diaphragm is the esophagus into the stomach. And so this can cause a couple things. One, it can cause some reflux. So that negative pressure up in the chest that the esophagus lives in may be enough to suck up a little bit of acid up into here and cause some acid reflux and some pain. And if it's happening long enough, or potentially if they have a congenital laxity in the lower esophageal sphincter area where it is coming in at the diaphragm, then they can also have a hiatal hernia. So this constant pulling on this may weaken this area that holds the esophagus in the chest and the stomach and the abdomen, and so you can have actual herniation of the cardia or portions of the stomach up and into the esophagus, which causes them to regurgitate and have discomfort. And so here's a fluoro image, a swallow study, some barium-coated kibble. And you can see here it's highlighting that the cardia, the shape of the cardia, is cranial to the diaphragm here in the chest, indicating a hernia. And she swallows a little bit more there, and it kind of pushes things through, but you can still see abnormal gastric anatomy within the thorax, which is an indication that something's going on there. So theoretically, if we can decrease the airway resistance for Sebastian, he may not have to try so hard with each breath, and then that driving force for the regurgitation, reflux, or the herniation may be reduced, effectively bringing us from our cocktail straw up to our nice boba tea straw to make breathing much easier. However, if corrective airway surgery does not resolve or reduce his regurgitation, he may need a surgery specifically to address his hernia. However, his combination of respiratory disease and regurgitation do put him at a higher anesthetic risk and a higher risk for aspiration pneumonia. I don't know if you can see here in this lateral where there might be a little bit of an alveolar pattern. Here it is right there. And so while this is a very real risk, it is low enough that we would still recommend corrective surgery for Sebastian to try and improve his breathing and his overall quality of life. So how do we fix him, Doc? What's your diagnostic workup plan for Sebastian? What surgical procedures can we perform to address this dog's brachycephalic airway syndrome? Take a few minutes to write down some answers here, think for yourself, or if you're working in a group, discuss in a group for a little while and come back. So this is what we came up with. A general physical exam once the patient is stable, maybe some blood work, thoracic radiographs to screen for aspiration pneumonia, and maybe a lateral cervical film so that we can estimate the palate thickness. You can see here in this green arrow kind of the outline of the soft palate. It's pretty thick. It's not completely obliterating the nasopharynx, but certainly if it were thinner, this would open up this space. And lastly would be an airway exam. We'll typically do these at induction at surgery, so we don't have to do another anesthetic induction to do the airway. Although sometimes I'm able to perform this airway exam and look at the laryngeal saccules just under the sedation that was done for the thoracic radiographs. So the treatment goal for surgery for a Brachycephalic airway syndrome dog is to surgically enlarge the airway in key locations to decrease that airway resistance. The approach for this is pretty straightforward and should make sense. The stenotic nares, we need to widen their opening in order to facilitate breathing and air passage. This elongated and potentially thick and soft palate, we need to shorten and maybe thin. The averted laryngeal saccules we can remove if obstructing the airway, although this is a clinician preference. Some surgeons prefer to wait and see if they will resolve after addressing the stenotic nares and elongated soft palate. And lastly, the hypoplastic trachea. Again, this is the one thing we can't really treat surgically. So for the stenotic nares, our goal is to increase that nasal opening. The way we do this is using an alloplasty, and it's a partial resection of the wing of the nostril. There's different ways we can do this, being vertical, horizontal, lateral, or even using a punch biopsy. Essentially, they all are pretty good, though, subjectively, at significantly decreasing upper airway resistance and improving breathing. Here in this case over here, you can see a preoperative, and then kind of halfway through, once we've done a vertical wedge, so we made an incision just like that, kind of probably in around an area just like that, and brought this tissue up, sutured it there to open up that aperture. And you can see already the difference. And then here we are after doing both sides. We do make every effort to make it symmetric, although sometimes it can be a little bit of a challenge. And this is going to, as you can see, a difference from here to there, greatly open up that airway for Sebastian. Next, we would address the elongated soft palate. And our goals for this would be to shorten the palate and alleviate its obstruction of the rim eglottitis. The landmarks we use for the caudal border of the shortened soft palate are the tip of the epiglottis or the caudal edge of the palatine tonsils. The most common procedure for this is called a staphylect, or essentially just trimming the soft palate to a normal length. So you can see in this diagram here sort of a dotted line of where we would like to, along the caudal border of the tonsils here, where we'd like to trim this elongated soft palate. it's grasped, the edge of the soft palate is grasped with an instrument, and then this is using the cut and sew method. You place a suture over here so that you have some control of where you're going to close, and you cut a little bit, and then you sew a little bit, and you cut a little bit, and then you sew a little bit. And that's how you maintain control of both the oral and nasal side of the mucosa as you close, and you suture all the way across here. And what this does is, again, as you can see, open up this airway so that the soft palate doesn't obstruct the rim glottis. This is sort of what it looks like post-operatively. You can see the epiglottis, caudal border of the tonsils, the epiglottis here, soft palate and the epiglottis just barely touch. So they can still seal off the nasopharynx if necessary. More recently described is a procedure called the folded flat palatoplasty, and this trims the soft palate, but at the same time it also thins the soft palate. It's a little less intuitive, so I'll show you a video after. So if you look at this image here, an incision is made about this shape in the ventral border of the soft palate, and then it's kind of scooped out to a depth right up to that nasopharyngeal mucosa. And all of this tissue is removed, okay? And so that's what this second image shows here. So it's much longer, but we haven't, or it's still long, but it's thin now. And so then what we do is we pull this caudal border here up to that cranial border of your incision there, and then we suture it back onto itself. And so ultimately, in the end, you have a thinner palate that is also short. And what I like about this is it pulls the incision with sutures away from that leading edge. Okay, so it's going to be way up here instead of flopping back here against the airway when they breathe. And so I just like that, because if there's any granulation formation or any issues there, then it's less likely to happen right in the business region here of the airway. And so here's a video demonstrating that. I'll kind of talk you through it. It's a pretty brief video just to give you the gist. So we're placing some stay sutures here on the corners of the soft palate. We have a gag placed back there so that any blood or saliva that builds up as we continue will not go down into the airway around our endotracheal tube. So I'm just measuring here to try and see, okay, if I folded this in half, where do I need to bring it up to in order for it to fold back there and have the leading edge be the caudal border of the tonsils? So I kind of mark where I think I need to go there if I pulled that up, and double check it there, make sure that I would be happy with that, and I would. And so then we use a needle tip electrosurgical unit, and we kind of mostly use a cutting setting here, but we outline what we need to do. There we go, we outline kind of our setting right along kind of that direction that I showed you. And then now we remove this tissue completely, and we try and get a lot of the tissue along with it. We try and get a lot of the palatine muscles along with it and the excessive mucosa that's there to really try and thin out this tissue when we pull it back together. And so we just kind of work through this slowly but surely, and we use electrosurgery to help prevent from bleeding. Every now and then you will run into a couple big bleeders, and you have to switch to kind of coagulation mode. We've sped things up here just to kind of give you the gist. Again, we're just working through carving down here. And more recently, since this video, you can kind of start to see the nasopharyngeal mucosa kind of popping through there. More recently, I've become a little bit more aggressive in removing even more of the musculature and thickness here, and I haven't seen any issues. But I really do feel like they do well post-operatively, and they have a much nicer breathing through their nose. So I've personally moved almost exclusively to this technique, and I've so far found some really good results. We're just continuing here, working on our depth and working on the tissue here, trying to avoid going full thickness. If you do go full thickness through the nasopharyngeal mucosa, it's not the worst thing you can do. You just place a little interrupted suture there to close it down. So now we've thinned out this palate, and if I pulled this up and sutured it together there, I'm still happy with about where it would be. So you can see that it right at the caudal border of the tonsils here should be about at that level. So I'm just testing that again there to see. Looks pretty good. And I freshened up that edge, and then now we're going to suture. So kind of speed things up. I like to put 2 stay sutures this direction, come back that way and tie, come back in the other corner and tie, and then come across in the middle. You don't want to suture all the way around because that might create kind of a purse string effect. So I like to have stops at the corner. So I like to have stops in my sutures at the corners here, so it doesn't kind of pull everything together as you tighten it like a purse string. I'm gonna just kind of speed things along here for the sake of time. Suturing through. Nearly done there. And then, yeah, here we are at the end. So this is kind of pulled up there. You can see our tonsils here. Kind of manipulating the epiglottis to show that it'll be right up on the tip there. And you can see that that leading edge is right at the caudal border of the tonsils. So that's what we were shooting for. So the next problem is our averted laryngeal saccules. And you can see them here from that video. Again, here's a screenshot from there that show these. And this dog does have a little bit worse laryngeal collapse than just laryngeal saccules in the video. And our goal is just to remove this this obstructive saccular tissue from the airway. Again, some surgeons prefer not to do this, but I typically will if they're in there and significantly contributing to the obstruction. And that procedure is called a laryngeal sacculectomy. We remove those. And so here's the video, kind of second part of that first video from earlier. So here I am just kind of grasping those and trimming those right before intubation after some propofol. Still have my sterility marker on my scissors like some sort of clown. But there's the first one there. I pulled it out and then I kind of come up dorsally there to resect this second one. You can see it's a fair bit of tissue to remove from the airway. And we typically try and avoid the most ventral component of the airway because we don't want scar tissue to heal across the bottom and cause what can be called laryngeal webbing. So, Mustache Mike, he loves his sea bass and he wants what's best for him. But what's this going to cost him? And so, using your hospital charges, why don't you generate a reasonable ballpark estimate for Sebastian's owner? And be sure to include some cushion for any urgent or unexpected things that may require additional funds. So take a few minutes to jot some of that down or potentially discuss if you are working in a group. Okay, so this is what we came up with for ours. It comes out to roughly about $3,000 to $3,500 at our institution, and so this is the estimate range that we would give to them out the door from coming in and seeing us, and then sending Sebastian home. If as long as there's no big complications, things like aspiration pneumonia or any other issues, airway inflammation that would require more urgent care would obviously affect this estimate. But this is our best guess moving forward. And so oftentimes clients will ask, well, what's the risk if I did nothing, especially after discussing finances? Because let's be honest, not everybody is ready, for an investment like this in their pet. And so sometimes they just want to make sure that they're making the right call and that they know all of their options. And so it's important to know what are the risks if we do nothing here. And so again, take a few minutes to write down some of the risks you think we could be, risking here if we didn't do anything. And if you're working in a group, then discuss amongst yourselves and come back in just a moment. All right, so here's what we came up with. For BAS sequela, these dogs can continue to have this episodic dyspnea. They can develop heat stroke because they don't exchange heat as well because of their abnormal respiratory breathing. They can get mucosal edema like you can see here, where there's this kind of thick, redundant edematous mucosa in the oropharyngeal region. And then, of course, you can have laryngeal collapse, of which the averted laryngeal saccules are actually already stage 1. The cuneiform cartilages coming together would be stage 2, and then complete loss of the dorsal rim glottis or kind of collapse of the corniculate cartilages is stage 3. Another thing they can develop is averted tonsils. So not sure how much this correlates to, to increasing in clinical signs, but even in our case with the video, you could have seen that those tonsils were averted. But it may help, it may contribute to the airway resistance and make things a little bit worse as well down the road. One very important thing about laryngeal collapse as a sequela is that we don't have a great way of treating it right now. And so the most effective form of treatment is usually with a permanent tracheostomy, which is something most owners, don't want to deal with. And so going through the preventative measures of, treating Brachycephalic Airway syndrome earlier may help prevent the risk or reduce the risk of having to deal with that in the future. And so regardless of what we do, whether we're doing surgical or not, medical management is going to be key. And the aims of this are going to be to keep Sebastian cool, calm, and slim. So weight loss is going to be key. Brachycephalic dogs should be kept slim. The larger they are, the more fat around that airway, the heavier weight they're carrying, the harder it is for them to breathe. And it's also easier for them to get overheated. And when they're exercising, to keep them trim, they should be on a harness, so not a neck lead, so you're not, irritating the airway. And you should be keeping them cool, like this dog. I feel like this dog looks pretty cool. But yeah, so when you're exercising them, it should be kind of minimizing outside activity on these really hot days. So maybe morning and evening walks would be best for these cases. Or, if it's just a hot season, just keep them inside, or try and do things that, aren't going to promote overheating. Another is avoid overexcitation, and sometimes preemptive sedation can be really helpful. So if you know your dog wilds out at parties, or when you have visitors, or if there's storms or fireworks, holidays, things going on, then it's best to try and avoid them from getting excited and having a respiratory episode, and you can sedate them preemptively. And then last, you'll want to avoid respiratory irritants. Some of these dogs may have worse respiratory inflammation around candles or perfumes or sprays or things like that. So it's best to avoid things that may irritate their airway to begin with. It's important to remember the procedure is not without risks, and complications could also cause this estimate to increase. However, we are well aware of these risks in these breeds, and we will do everything we can to minimize their occurrence. We wouldn't recommend this surgery for Sebastian if we felt the risks were too great for his anesthesia and surgery.
Yeah, all right. Well, let's do it, man. Let's do it.
All right, Mustache Mike approves of the plan, so we're going to move forward here with our pre-medication plan. In this case was dexmedetomidine and methadone. And I personally like to use an anti-inflammatory dose of steroid. This is something I picked up from one of my mentors, Dr. Ellison. And I give him a pretty good dose of anti-inflammatory dexamethasone XP, usually at induction or at pre-medication. Pre-oxygenation is going to be very important. And in this case, you can always give some smooches and snuggles. Those won't hurt as well. But you want to pre-oxygenate them so they're as oxygenated as possible during intubation. And in our case, during the sacculectomy without intubation. Although some surgeons will perform the sacculectomy with the patient intubated. We'll get an IV catheter in, and we gave Cerenia 1 mg per kg IV, because it's just, if we can do everything we can to combat the risk of regurgitation or vomiting, nausea, aspiration, pneumonia, then we can. So we will typically treat them with Cerenia. We would induce with propofol, 4 mg per kg drawn up, but would give it to effect. Then we would do our surgical laryngeal exam and the sacculectomy if indicated. We would intubate, and we would keep them on maintenance for isoflurane at the lowest MAC required to keep them under. Our surgical plan, so we went ahead and did all the things. And so we did our sacculectomy at induction. We then did our folded flat palatoplasty. There's an intra-op pick right up here. And here is some saccules that were removed on the tip of my glove there. We did a vertical wedge and opened up these beautiful nostrils over here, and went to recovery. And so the patient did great during anesthesia and surgery. So what would be your postoperative plan for Sebastian after this? Why don't you take a few minutes to write down some answers, and if you're doing this with a group, take a few minutes and discuss amongst yourselves. So our plan was to recover Sebastian in the ICU in a cooled oxygen cage on room air. And that's just so that in the event that there is an emergency, we're able to kind of turn the oxygen on immediately and keep him in a climate-controlled area to really help him help support him the best we can. We also came up with some of our evaluation plans here. And so a respiratory watch is a good idea, just to monitor hourly the respiratory rate so you can kind of catch anything early that they may have had. We'll keep them on some maintenance fluids overnight. An opioid as needed every 4 to 6 hours, although these typically aren't too painful, and I will often inject a little bit of bupivacaine into the folded flat palatoplasty site. We like to keep them on pantoprazole because of their reflux disease and regurgitation. And again, meropitant as an anti-nausea medication once a day. If regurgitation continues or is bad, we may consider some prokinetics such as metoclopramide or cisapride. And typically I like to feed them formed meatballs in small amounts at a time. So we'll feed them 3 or 4 formed meatballs of canned food about 6 hours post-op, and then about 3 times a day or so. Once they're eating, we like to get them onto gabapentin, 10 mg per kg every 8 hours. We keep a soft e-collar on them so that we can protect our nasal sutures. Then, of course, we walk them outside. And so, fortunately for us, we had a very uneventful recovery. These dogs were doing great outside. For example, that's one thing I like to do. I'll take them outside and see how they breathe and how they're doing and listen to them and make sure I don't hear any evidence of aspiration pneumonia. And this dog over here was obviously letting us know that he was ready to be out of oxygen, poking his head through there with his little e-collar. And it's nice. Sometimes you can hear a difference right away. And they're just so happy they can breathe. Sometimes they'll say thanks in a very weird way. All right. Mustache Mike is grateful, but it's time to send our little boy Sebastian home. So what is your at-home care plan for Mustache Mike to follow for Sebastian? Take a few minutes to write down some answers here or discuss amongst yourselves if you're working in groups. Okay, so for our at-home care and follow-up plan, we came up with this. We wanted to keep Sebastian calm and quiet for 14 days while recovering and healing. No rough housing or playing or any excessive activity. No chew toys because we don't want him to chew and damage the sutures in his mouth. He should be in a kennel when he's unsupervised to prevent overactivity. And when he's outside, he should be on a harness and leash. Ideally, we would feed him a soft food for the next 2 weeks, again to protect our suture site, and I like to feed him as formed meatballs for about the first week after surgery. We'll send them home with trazodone, 4 mg per kg as needed for sedation, and gabapentin as needed for pain. An e-collar as needed as well if they tend to scratch at their nose sutures, although surprisingly most of them don't scratch at their nose sutures, but I will always send them home with one just in case. And then we typically will see them back in 10 to 14 days to look at the incision side of the nose for healing and listen to the breathing and make sure that there were no issues. If regurgitation has not improved in 4 to 6 weeks, I'll consider adding cisapride and see how they do after that, or a swallow study to rule in or out a hiatal hernia. Okay, and here's an example of a nice 2-week follow-up. Hopefully you could hear the difference in their breathing. How nice the nose looks now. Or hopefully you can't hear that, rather, because compared to the preoperative ones, it's much quieter. And so great job. We've made it through this clinical case. You'll get some nice thank you photos of family members really enjoying their dog's new lease on life with the ability to breathe a little bit better. And thank you. If you have any questions, just comment on this video. Feel free to share it. We hope you enjoyed this digital clinical case experience and that it helps you all continue to grow as a clinician despite these unprecedented circumstances. Remember to do the 5 to help stop coronavirus. And again, if you're a veterinary educator and would like to upload a Vice Rounds of your own for sharing, you can contact vice.rounds@gmail.com. Special thanks to all the people who made and released these awesome resources for free. The presentation template was adapted by one on slidescarnival.com. Icons were made by FreePick and Monkkick from flaticon.com. Big thanks to Mustache Mike for being a great client and helping us out here in a pinch. I did create this rounds presentation, and all images are personal or references were provided on the slide. And lastly, here's a nice moment of zen for you before you guys get back out into the real world. Enjoy. Thanks again, and be safe out there.